Hello and welcome, everyone. My name is Renee Garrett, and I'm your speech therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Tiffany Hoeft is the owner and founder of Minds Matter PLLC and receives an honorarium for this podcast appearance from Speech Therapy PD. Her non-financial disclosure is that she's a member of ASHA, a certified brain injury specialist, and is a board-certified neurofeedback provider. My financial disclosure is that I'm the owner and founder of Brain Bridge Connect LLC, and as the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on speech therapy PD, I do receive financial compensation. I'm also an adjunct instructor at both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Questions can be written in the Q&A or the chat box and will be answered throughout the presentation. Now we welcome our guest, Tiffany Hoeft, MS, CCC, SLP, CBIS, CGCP, BCN, who is a speech language pathologist with over 23 years of clinical expertise in cognitive rehabilitation, geriatric care, and dementia management. She began her career working in skilled nursing facilities, rural clinics, and hospitals in Minnesota and South Dakota. Along this journey, she realized that as a rural SLP, she needed to be both the expert and the educator for her clients, helping them understand both their disease and prepare for the path ahead. She became a master clinician in dementia and an ASHA ACE award winner, focusing her education on cognitive communication deficits and the prevention and restoration of cognitive function. As a certified brain injury specialist in South Dakota's one of two now board certified therapists in neurofeedback, Tiffany incorporates multiple treatment approaches to enhance her clients' quality of life. She founded Minds Matter PLLC in Aberdeen, South Dakota, to offer innovative, evidence-based approaches that optimize brain health for all adults. Tiffany, it's so great to see you again. Thanks for being here.
Thanks for having me.
Of
Really
course.
excited about this.
Me too. So I've been starting off a lot of the podcasts lately with just kind of connecting you, the guest, to the audience, and really to me too, and like learning about people's why, because I say this a lot to my students about the development of your reasons why you go into the field, but also why you stay in the field. So are you comfortable sharing with us your why you became an SLP?
Absolutely. I was a little type A, and in high school, I knew exactly what I wanted to do. I wanted to be a speech pathologist, and I knew I wanted to work with adults. And then my freshman year of college, two of my friends had a really bad car accident,
Mm,
and it was a horrible accident. They spent months in rehab, and I would drive from Moorhead, Minnesota to Sioux Falls, South Dakota, and shadow them going through therapy. And watching that really solidified like brain injury rehab and working with adults. And then through the process, went on to St. Cloud State. I was fortunate enough to have, Christina Keeler was an amazing person to work with. And I had amazing professors in neuroanatomy. The first time I got my hands on a brain, I thought like this is the coolest thing ever. So it's kind of led to this journey, all adult neurocognitive focused. I did my internships with kids and they were a little too fast for me, so I stayed working with adults the whole time. And
yeah.
then along the way, I was at United Hospital in St. Paul, and it was an amazing internship and got to learn a lot. But I also learned that I did not like living in a city. And so took my first job in Wilmer, Minnesota for a therapy company and worked all over the place, all over the state. But the best part of that was I shadowed or was able to look at the plan of cares of so many speech pathologists that I got to see, oh, this one does it this way, this one does it this way. And it really built up my professional knowledge, I guess, and permission to treat in different ways. 23 years ago, treating dementia was a little dicey. The older
Mm-hmm.
speech pathologists that I would work with would say, nothing you can do about them. I had a hard time getting doctors to sign orders, you
Mm-hmm.
know. Yeah, so it's kind of just been this out of necessity growing into different areas of speech pathology because sometimes I'm the only person other than the nurses in a rural hospital. And yeah, you have to learn a lot and know a lot about everything. But
Yeah, that makes
great
total
field.
sense to me. And even, I myself work in a less rural, but less rural than where you are hospital. At the time I started there, things evolved really quickly because it was a rapidly growing area with, new housing coming in. People were coming in from the bigger cities who didn't want to live there anymore. We have a military community here where I'm at. And so there's always rapid growth in that aspect. And so it was, yeah, watching things kind of evolve and change even in that rural hospital space, I'm sure was probably there were some similarities probably for you like there were for me on how, you know, it started out we might get 2 orders in 3 days and then all of a sudden by the time I left I'm getting 15 to 20, new orders for evaluations and especially during the COVID post-pandemic kind of time. So tell us about your work at Minds Matter. What led you to focus your SLP career on both helping people protect their brain function, but also improve their brain function?
So Minds Matter started out of a frustration working the first 17 years in nursing homes and, small town hospitals, this whole mix. But I'd look at these people and think, gosh, if you had some kind of help at home, or if you'd started earlier, you wouldn't have had to be here. You wouldn't have had the fall. You wouldn't have, missed your medications. You wouldn't have done all these things. And so it started out for a long time just being frustrated. In 2012, I had West Nile. And so I had brain fog before brain fog was cool. And at that, I know it, I would talk to my doctors, and they were all wonderful caregivers, but and say I'm not the same. Every night I used to do a Sudoku puzzle before I go to bed, and I can't organize anymore. I can't problem solve. Like I can get through my day, but I can't do these high level things. And it really changed how I do therapy because you know naming 15 animals just didn't really help me out a lot in that situation. So I really started looking at all sorts of different approaches that are still within the realm of speech therapy, but working on post concussion and post COVID when that came along and just working on these higher level skills. And so that's Minds Matter is a clinic. I get the people that don't have a diagnosis that are, you know, maybe going through menopause and just a little bit off and want to do something. I'm getting just doing this whole preventative part. I still have my people that come in with dementia. I have the whole realm of it. But yeah, the whole point behind Minds Matter is I want to do therapy the way I want to do it. I don't want anybody to tell me how to do it. If I want to sit out in somebody's car in the parking lot and put sticky notes so they remember to put their vehicle in park, I get to do that now. And yeah, that's kind of where it all came from.
So at what point and this is, kind of more my own thought, at what point did you become interested in neurofeedback and sort of implement because board certification and anything is not easy. It's not quick. There's a lot of work behind the scenes for anything that we do that's a board certification or anyone, that gets a board certification. It's typically a lengthy process and a lot of work. So what led you to that?
I was exposed to quantitative EEGs at a clinic that I was working with here in town that another physician had started. And it really opened my mind up to okay, there's something out there other than this structural assessment, which is an MRI or a CT. And through the process, then I didn't want to kind of do it. I didn't want to just kind of understand it. And it led to me figuring out how to get board certified. And that was a process because I had to take neuroanatomy again. I had to, go to different states and get supervised and learn all of this. But neurofeedback it's like biofeedback for the brain. And
Hmm.
so it just helps people quantify a little bit more what they're doing in speech therapy. It's been a way for me to show, you changed your brain waves through what you're doing. And yeah, it just makes it a little more concrete because I feel like in physical therapy, it's easy to see like, well, I went from the 5 pound weight to the 10 pound weight, or I walked, a foot and now I'm walking 20. And this provides that kind of concrete data for that.
Oh, that's really cool. I really didn't know that because I think most of us, if we work in the medical setting and are familiar with EEGs, especially if you're a stroke rehab certified hospital, your patients are getting that stroke workup initially, and that's usually part of it is just an EEG. We know that with our brain injured patients, there's an increased risk that they could have seizure activity post TBI, even as far as, development of post TBI epilepsy. And so I think, that's sort of what I was thinking. So I was very interested in hearing kind of what that looks like and how you came to that. So can you explain how a acute EEG brain map helps you really see what's going on with a person's thinking and memory? And give
Yeah,
us the
so
details.
yeah, in our brain at all times, we have four different kinds of waves being made. We have these delta, slow, sleepy waves, and then we have theta waves that are a little bit faster, but that's where we process emotions. And then there's alpha waves, which kind of sound like the alpha dog. They manage the whole brain. And then there's beta waves, and they are these really fast moving waves that we use for high level thinking. And so what I do here is I do this, put on an EEG cap on my patient and acquire the data. And then I send that to a clinic where their brain is compared to thousands of people, at the same age, and just see how far out of the norms they are in certain areas. And it really tells me, is this an underpowered brain? Do we need to really work a lot more on cognitive stimulation? Is it an overpowered brain because you have a lot of anxiety? Are you making way too many of the delta waves? Is that, predicative that you're going to have dementia in the future? It's just comparing your brain waves to 1,000 other people in your same age range and really looking at the normative data. It's been really, really good, especially for my brain injury people, because it's, post-concussive syndrome,
Hmm.
especially in rural South Dakota, starts turning into mental health. You know, you that's the crazy one that needs all the help is, it, it's not really well understood. And
Hmm.
so the doctor sees you've got the normal MRI and your CT doesn't show any damage. So you're normal. And so now this is just depression. And then I'll have somebody come in and I'll do a quantitative EEG on them and say, well, your structure of your brain is fine, but your function of your brain is not. Like, you're creating way too many beta waves. And that's where you're getting all this anxiety and overthinking. And when you're trying to come up with a word, you're having 30 thoughts in the time that somebody else is having one or two. So let's slow that down. Yes, through traditional speech therapy, but also through neurofeedback, and, get your brain back on track. And it's just really, really validating for somebody who's been told they're normal and this is now just all in their head, to see for the first time, like, I'll have them bring in their spouses, their girlfriends, their whoever, and say, like, see, I'm not crazy. And it's pretty meaningful.
Yeah, I can imagine. I mean, because again, we know with our, particularly with our TBI patients, we see a lot that it's a silent thing for them. They're going to community events or they're back at home with their family, and people that are maybe a little removed and don't understand brain injury are, oh, you look fine, you walk fine, you can carry on a conversation. But then, you can't figure out how to get from your house to the grocery store, or you can't figure out how to make your own appointment, and all sorts of other everyday tasks that people need to be able to do prior to being able to go back to work. Because for the longest time, it was that whole RTW, return to work. Ugh. It's
Yeah.
like one of my pet peeves, because you can't expect someone to go back to work if they can't get up in the morning and make a bowl of cereal. They can't sequence, how to take a shower because they're so not only cognitively having some impairments, but then also the mental health piece of having to hear, oh, but you're normal and you look fine. And that does weigh on people.
Well, it does. And just this last weekend, we had the Out of the Darkness suicide walk. And,
Hmm.
I'm trying to do more education of the reality that people who have post-concussive syndrome or traumatic brain injuries are more likely to commit suicide or have suicidal thoughts and depression. And it's a big deal. But I always tell people, even a slight concussion, let's say your brain is 1%, a 1% decrease in function from where it was before you had the concussion. Well, that's a big deal. That means that at work you were able to, have five different things on your plate, and now you're losing them all and you can't work at the highest level. And of course, you're going to be depressed
Hmm.
and it's going to snowball into a lot of different things. And yeah, you're probably going to go to the dark areas because you can't problem solve through your situation.
Yeah, and incidentally, and I really hadn't, I thought about it earlier today, but I hadn't thought about it until you said it. But today is September 8th, which is 988 day. So it's the suicide hotline. That's their number. And so that's an awareness thing for us to be mindful of too when we're working with patients with neurogenic disorders, because it can be anything from TBI to Parkinson's to other neurodegenerative diseases and stroke, right? And so, yeah, I think it's just another tool in your toolbox, as I like to say, to figure out what can we do, how can we do it, and what, again, like you mentioned, giving that concrete data to a patient and their caregivers. A lot of times too, it's super helpful for them, the caregiver, to see that this indeed is a problem, and this is something that we can compare back and, 4 weeks or 8 weeks or whatever your care plan looks like.
Yeah. And that's a big part of therapy here is the caregiver is always in the room, sitting behind
Mm.
me. There's a nice comfy chair where they come and the caregiver comes and sits in here. And sometimes they kind of expect that they're just going to drop somebody off. And I'm like, I want you here for the testing. I want you to hear that I just gave your loved one 4 digits and they can't repeat it backwards. Okay, so now you say go to the store, get this, 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 and this, and you think they're a jerk and they can't remember. This is the reality. So we do a lot of just explaining like this is the functional reason why your person's depressed. And that education piece, I think, is a huge part that sometimes as speech pathologists, we know a lot, but we don't relay it to the families.
Yeah, no, and that's always been a huge push for me. I have a bit on the other side before I was an SLP, as a family member and a caregiver, was making sure that I do as much with education and providing a diagnosis that's a speech cognitive communication disorder diagnosis, because 9 times out of 10 when the patient would come to me, especially when I was working an outpatient, they'd never heard the words cognitive communication disorder, aphasia, executive function disorder, whatever it was. They hadn't heard that before, and so it was really really eye-opening to be on both sides of the coin, if you will. And one of the things that you mentioned earlier was West Nile, but you're seeing clients too post COVID, Lyme disease, and you mentioned concussion earlier, but what are some things we might see post COVID, or even we could talk about both post COVID and Lyme disease, because I think it's really interesting. It's been Lyme disease in particular has been more in the media, I think, this summer, at least in my area. I'm in Southeast Virginia. We had an uptick in tick-borne diseases here. And so, what are some things that you see that would lead you to kind of maybe thinking outside the traditional norms of what we do as SLPs for something like COVID or Lyme disease?
Yeah. So, some of the things that I'll see is people will just notice they're a little bit off, right? Like, so if they're students, it's the A student that's now the C student and just not able to process the way they could. I see that irritability being the first thing, I'll ask the client that's in here, do you notice any changes in mood? No. And then the loved one sitting back there is like, yep. And, not being able to keep all the balls in the air, you'll start seeing the checking errors, just going to the grocery store, forgetting things, not knowing the car is, but it's really slight, small changes. And I've been trying to do a lot of education with the doctors around here that if somebody's brave enough to come to your office and say, hey, something's going on with my memory, attention, whatever, like please do not say it's just going to get better in a year, or just give it time, you need more rest. Like, and I just keep going back to, if you tore your ACL, you would never go into the doctor and they'd pat you on the head and say, come back in a year and let's see if it's better. Like they would get you into therapy. And so it's that education piece, because all of us as speech pathologists, when we get these people, we can see what they can't sequence, they can't reason, they can't do abstract reasoning, they can't name, they can't stay on task. So it's more just getting them into our offices, I think, is the big hard part.
Yeah, no, I agree. And it's like you said, the education with physicians is super important because, we like to think that even if you're neurologists have different specialties, right? We have our movement disorders neurologists, we have our MS specialist, we have just different things like that. And so not everybody who is a physician had a really solid neuroanatomy course. They definitely didn't have a solid what does therapy bring to the table course, right? They don't really understand, and a lot of it is seeking out the knowledge or learning on their own, but a lot of it is us being that proactive person who's going in and saying, "Hey, we've seen like I said in my community, this uptick in tick-borne disease. If your client or your patient's coming in and they're saying they've had a cognitive change, they need a referral. They need to be referred to the appropriate source." And then also, like with post COVID, I know that, a lot of people don't want to talk about it, right? They're like, "Oh, I still hear people say COVID was fake and it doesn't have long lasting effects." I know when I had COVID, the first time I had it, I did have the cognitive fog, and it was really hard because I had to go back to work and I was treating patients with the same thing. And it was really, not only was it the cognitive fog, but it was like slower processing speed. It was quicker to fatigue cognitively. And so is that kind of what you also see with your patients that are coming in and they're like you said, they're coming into the physician, they're like, something's not right, but then they come to you and that's the kind of description that they're giving you.
Yeah, and before I go there, like what you mentioned about specialties, I think that's a really important thing too, that not all speech pathologists are specialized in this. So,
Yeah.
you know, you'll get maybe the referral to the hospital therapist that sees a 1 year old, then a 105-year-old, then a 90-year-old, and does a video swallow. And they'll get this cognitive person and do a slums on them and say, well, they're 23 out of 30, they're fine. And I'm like, oh, you're breaking my heart, because 23 out of 30 when you're 45, like that is not okay.
No,
And
it's not.
so it's also knowing when to refer, right? Like if that's not your thing, know who in your community is the person who loves adult acquired neurogenic disorders, because we all have that. But now I totally lost track of your question.
No, it's fine. It's thinking about the symptoms that you see with like long COVID patients or those other sort of I don't want to call them outliers because really it's not anymore, but I think for a large part of our community, they just kind of want to make it go away, especially when it comes to post-COVID. They don't want to hear about long COVID patients. They don't want to maybe acknowledge that it's a problem, but it's a problem.
And it definitely is. And you're right, like that fatigue, the processing speed, that is, especially like on the brain scan, I see a little bit more of that. And it's a little bit more black and white. It's, I always explain to them, you have your marbles, on the scan, I can see you've got great cognitive function, you've got excellent power, but your speed is so delayed that you're driving and a deer pops. We have a lot of deer around here. A deer pops out of the road and your spouse is like, put on the brakes. And after you hit the deer, you're like, what was that? That's where we're at. And it's not dementia. I mean, you knew what it was, but it was just so slow. And if you can speed that up, you can get back to real life and functioning. But yeah, that processing speed is a big one, and the overwhelm. And it's just life is too much anymore because they've lost organizational strategies. And
Mhm.
especially like the people who are really, really smart didn't have to rely on schedules, planners, notes. They kept it all in their head. And then that 1% change from COVID, Lyme disease, whatever, took away the ability to hold all that in their head. And now all of a sudden they're failing at life because they never had to use any strategies before this. So they don't even have them. And yeah, so us being able to give them those strategies and educate them that this isn't dementia, this is just a change in your brain function, but you can rehab this is huge for these people because, they're again that depression, like I'm just different for the rest of my life. Like, well, no, you're different for right now, but we're going to get there. That's
Yeah, and
been a big
it's
part.
kind of reminiscent of for people who have had children, whether they're the mom or the dad, either or. When you have broken sleep, it's very similar to that. But your broken sleep, once your kid starts sleeping, goes away. You get better over time.
Yeah,
But
and then you go through menopause and you quit sleeping and no.
yeah, but the cognitive fog thing is such a huge piece because it can be tied to hormones or hormones. Oh my God, I made a new word. Hormonal changes. But when we think about our patients with things like TBI, other progressive neurological diseases, they're having neurotransmitter chemical changes in their brain, which can mimic sort of that same type of thing we see with hormonal changes, right? We're seeing people who maybe they are less inhibited or maybe they're more inhibited. Maybe they're apathetic now and it's just really there's so many layers to this and so many pieces. So I think that that's kind of the fascinating part of what we do when we're looking at all these different things because it's not what came first, the chicken or the egg. It's like, okay, we have these layers of things that we have to work on, and where do we start?
And the part that I think is really tricky about COVID is it's not that acute onset. Traumatic
Hmm.
brain injury, right? Like we know February 14th, your life changed.
Hmm.
But when you're dealing with COVID, it takes a while, like you recover from it. And I mean, I have a lot of people that had it really mild, you know, and so they don't attribute it to that. And then we start digging, and I'm like, when did this happen? What was the start date? When did my in thinking then they'll go back and say, oh my gosh, it started like when I had COVID or it started after this. And but it's that slow buildup in the cognitive changes. It's hard to attribute it. So all of a sudden they're just like, something's wrong, but I don't know what it is.
Yeah, and it's really impacted a lot of people's ability to return to work, right? And so, like you mentioned, like even people with mild, I knew someone who used to help me with the podcast who her spouse had an issue with it, and he was fairly young, and he had to take a pretty long absence from work because of the cognitive fatigue, the lack of stamina, increased processing speed that it was taking him to be able to do things, and he wasn't really super, super sick. So it was very interesting during that time to work with her, to talk to her about it. But I think too, kind of switching gears, because you are a certified dementia practitioner, you're often working with people after they've got this dementia diagnosis and you're meeting with their family or their other caregivers. So how does that work out? I mean, how do you start those conversations?
Yeah. So what typically happens is somebody will get referred to me and they have a diagnosis of dementia, newly diagnosed. And they come into the office and, this is somebody who where I live in, Aberdeen, South Dakota is a town of about 30,000. So to go see the neurologist, they make the 6 hour drive and they have their, depending upon which neurologist you get, they get their quick appointment and you've got Alzheimer's, come back in a year. Here's a drug. And so somehow they like find their way, usually through their primary care around here, they'll say, maybe you should go talk to Tiffany. So they'll come in and I'll do a little bit more testing and talk about, okay, here's your strengths, here's your weaknesses, but we're going to fight this because like no matter where you're at, you can always improve your brain. So we're going to fight tooth and nail, and I'll watch how the husband and wife communicate, or the caregivers, or whoever it is, and say, well, you're going to be part of the problem here pretty quick, because you have taken away her ability to drive, you've taken away her medications, she no longer gets to cook, you took over her schedule. Like, if we think of her as a 10-year-old and you want that brain to grow, you give them more and more responsibility, not less. So here's how we're going to start managing this and giving back as many of these duties as we can to help this person be as independent as possible. You know, I'm looking at, how do we stay driving as long as possible? How do we stay
Hmm.
in your home as long as possible? And I always tell them that, like, aging is a team sport. The more people we have on your team, the better you're going to age. So what's that look like? And then, my OT might take over and do some of the treatment, and I'll keep the family member, with permission from the patient. I'm like, can I talk about you behind your back? And they're like, absolutely. I'm like, okay, here we go. You get away, because we're going to talk about some stuff. And then the sometimes I'll have this room packed with family, and I'll say, here's the hard decisions that are going to come up with this diagnosis. Along the lines, you're going to run into swallowing trouble. What are you going to do? Along the lines, you're going to have toileting issues, you're going to have this, you're going to have this. How are you going to handle all of these issues? What are, I always call them the non-negotiables. Like, what are you willing to do as a caregiver, and what aren't you willing to do? And then I belong to this group, Dementia Friendly, and we put together, all of our resources that we can think of in this area. And I say, your job from here on is, we're going to prepare for the best, but you're going to tour every one of these facilities. You're going to come up with a plan. You're going to know about how much this costs. And we just go through the whole nuts and bolts of, this is what you're looking at. And it's been really good, because I don't say I'm going to cure dementia, but I say we're going to put up the best fight we can and live the best that we're going to with it. And that's been a really big piece to what we do here.
Yeah, well, that's amazing because that's such, such an integral part in, that whole roadmap part because no one else is really talking them through this, right? Like you said, they go to the neurologist, they're like, "Hey, you got Alzheimer's, get you some Aricept or Namenda or maybe a little of both and come back next year and we'll repeat your baseline testing." My mother-in-law had Alzheimer's and it was a lot of that, even though I would. Because, gosh, I don't really know anything about it, any of that stuff, so no one wanted to listen. But it was frustrating because, we do this for a living and we do have that base knowledge. And I'm like you, I spend a lot of time on education for myself. Like I spend my CEUs on things that I feel like will benefit my practice and will benefit my patients and will also benefit me so that I can be the best provider for them and help them advocate in these really murky, weird waters, right? And so that part was really just really tough because I am one of the people who knows what I'm doing. I think you know what I'm doing most of the time. But it was very frustrating because I'm trying to help with the roadmap and no one wants to be you're using like Apple Maps, which is notoriously not that great. Sorry, Apple. And not using Waze, which is what we prefer out here on the East Coast for the most part. So that part was frustrating.
We have like
Um,
two highways. So we just use, do you go east and west or north and south? No, we're not
that
that
would
small, but yeah.
that's nice. I would love that. It's yeah. Yeah, there's been a long going joke because when the government workers here went back to in office after being virtual for so long, the traffic is. Oh my God, it's just it's nuts. It was nuts before the pandemic, and then, I was working at the hospital during the pandemic, and so my 28-minute commute went to 17 minutes, and then now it's like a nightmare. So that's a whole nother thing. But we did have a question, and I apologize, Michelle, that I didn't see this earlier, but the question is, after therapy, do you see measurable changes in the EEG?
I do. I will say, because the EEG is out of pocket, it's not covered by insurance. So I do a lot of pre EEGs. It's hard to get the post, because everybody's like, I feel better. I'm so much better. Why would I spend the money on another one? And
Mm-hmm.
so every once in a while, I'll just say, hey, we're going to do one because I just want to know for myself where you're at, pre-post. And yeah, there's definitely, I'll see changes in autonomic nervous system, and I'll talk about like, okay, you went and got that CPAP and look at what's happened in the area of sleep. This is what's improving. Just kind of going through the real functional changes with progressive, neurological. If I really suspect it's Alzheimer's, you won't. I mean, the brain is continuing to decline, but I hope at a slower rate than it would have without therapy. But yeah, there's that pre and post that you do get to see.
Yeah, and back to the dementia, we see a lot with by the time we get them or by the time they have a formal diagnosis, they're, on the global deterioration scale, they might be they're 4, right? We're not seeing them at 1 or 2 because we don't even the physicians aren't going to really note measurable cognitive change. Maybe they're feeling like the patient might be feeling like they're forgetting something. And I'm teaching an aging and communication course right now. And what's been funny is listening to a lot of the students, because it's an online course, a lot of the students are returning adults. And so they have a little bit of life experience. So not only are they experiencing their clinical placements, but they're also experiencing like real life grandma, grandpa, mom, dad, aunt, uncle, whatever, who have had some of these diagnoses of various types of dementia. And so one person spoke up and was talking about her mom having Lewy body dementia and how she kind of felt like it was almost like they gave her like a death sentence. They were like, we have this and there's nothing we can do and best wishes. And that was
Yeah,
so heartbreaking to hear that.
I gotta give me 1 second. I just gotta grab some pictures. So
Monica,
this
I
is
see
not
your
in the
question too.
plan.
I'll ask that in a second.
So this is, I always say a picture's worth 1,000 words. And so I got to show this. This is somebody who has a diagnosis of Alzheimer's. And, I asked her husband what lights her up. And he said, well, drawing does. So I'm like, bring me some of her artwork. So this her, her baseline before Alzheimer's.
Hmm.
And so I'm like, well, we're going to do something that like makes your world happy. And so I tell her the first day, I'm like, draw me a cat, like draw me a cat like this. So she works really, really hard at it. Has to have the picture in front of her because she can't initiate. She can't think of it. It's still far better than I would ever draw. But
Same.
then I go to their house. We set up an art station. I work with him because he was an overprompter. He snapped at her. He was the don't you remember? Don't you remember? We worked a lot. And so, here she is 3 months later.
Oh, wow. That's beautiful.
It's beautiful. Like there's shading, there's detail,
Yeah.
and
Beans in the leaves of the petals of the flowers. Yeah, that's really cool.
yeah. So, like in that lady's world, she lights up every single time she draws. And she came back for a couple years. She wasn't back this summer. I kind of suspect, they go south for the winter, but I'll take an hour of quality every single day for a little bit of a few months of work. And it's just those kind of things like, yeah, the more education we do, the more we understand how important we are as speech pathologists. And it goes beyond we're gonna name 15 animals.
Right?
Yeah.
So Monica asked, do you use any type of video or screen game designed to recover or train cognitive function?
So video or screen game, are you talking like something like the online brain games that there are? Or are you talking like with neurofeedback? Do I use the screen games? Because as we're waiting, if she clarifies a little bit, my neurofeedback is extremely boring. You stare at a screen, and when your brain makes the right type of waves, the green circle gets green. I actually prefer that over the game type ones because you can get a little lost in the TV show or whatever you're watching, and you're there to make your brain work.
Yeah,
And then
she said either.
okay, and then in therapy, especially as I'm working with my higher level people and transitioning out of traditional therapy. Like I always tell people, the goal is to get rid of me. So as they're transitioning out of therapy, then I do look at, you know, can I use their names on here? I'll look at, some of the big companies and the subscription based cognitive tasks, but we'll go through them and I'll say, but we're going to think of this like a therapist, right? They want you to do this fast and faster and faster. I want you accurate. I want you hitting the pause button. I want you learning how to hear Tiffany in your head when you're doing this, saying, okay, they want me to remember this really fast, but I want to hold on to these three numbers for 30 seconds while I go grab a pop and come back. And then, that's the kind of changes I want made to the brain. So I use those things, but in an entirely different way than those companies want them used.
Yeah, because you're trying to increase cognitive load while almost like more like a multitasking or a task distraction in the middle of that, the central task, and then you're doing something else, and then you come back. So that alternating attention, that was the word
Yeah.
alternating attention. And I
I,
think that's what you were describing.
well, honestly, like after 23 years, like my whole job is to get my patient to understand what's going on with their brain. And so I spend a lot of time dumbing things down. And so when I have to go the other way and use my big words, like it's not very often that I just get to talk to a speech pathologist and have to talk about alternating attention. And I'm like, oh yeah, that is the word for it. I tend to say it's, that thing where you walk into the room, like, why did I walk into here? That's the kind of memory why we're gonna do this. So.
Yeah, no, I do. I'm very familiar with that. And usually what happens with me is I'm already thinking about something else, and that's why I forgot why I went in the room in the first place.
Well, our spirit animal that minds matter is the squirrel. Like,
Oh,
I'm always shouting
fair.
that person, people like, squirrel, what happened there? So
So there's another question. Is there any research articles that you know of that, and we can post this if you know of anything regarding benefits or functional outcomes of patient success with speech therapy in patients with early stage dementia? And I can
there's
kind of answer part of that because mild cognitive impairment, there is a lot of research with that. And we can certainly, and Tiffany, you answer, but we can certainly compile some things and put it in the show notes on the Speech Therapy PD website.
Yeah, I can work on the exact articles. I know the research is out there, but to come up with that, like I said, that's not my strong suit is the research end of things. It's the what do I see in my office? And
Hmm.
I'll tell you from a patient by patient basis, I see a lot of those people walk in with 23 out of 30 on the slums. And I do give the slums and I do give the MOCA, even though they're not standardized tests, but our doctors like those 30-point numbers. I
Yeah.
see them walk out with 29 and a whole understanding of how their brain works and how what they're doing is and isn't working. And so I have a lot of patient by patient experience.
Yeah. No, and I have some stuff on mild cognitive impairment that I can put up too. Let's see. Heidi, I've noticed sometimes boring is better in my speech therapy sessions, much more controlled and accurate outcomes. Yeah, are you talking about like giving the patient extra time and making sure they have time to process? Is that I'm assuming that's what she's talking about? Yes, and nothing too distracting. Okay, yeah.
And I will go back to Dr. Gerald Lavoie at St. Cloud State when I walked into a therapy, my student treatment session to see this little guy. And I had a stack like this of games and bells and whistles, and I was ready. And he's like, here, Tiffany, let me hold that. And he takes it and he puts it away and he shoves me back in the room and throws me a box of Kleenex and he's like, go. And so I had an hour in a room with a little guy and a box of Kleenexes. And you know what? The best thing that happened to me because being in rural South Dakota, it's me and my car and a deck of cards and let's see what happens. And I think we get too focused on what's the right workbook, what's the right.
Yeah. And that's so funny because I was just saying probably a couple episodes ago how I was so mad when I got done with grad school and I found out about this whole world of things that were available that we could be using in our therapy room. But then, like, we had to reinvent the wheel when we were in grad school. But now that I've been in the field, I appreciate it because you can give me a magazine or a newspaper and I can therapize you for hours. It's fine.
Yes.
So it was really preparing us for that thinking outside the box, because when you work with these populations of dementia and TBI and other neurological disorders, it really is, you might have the best therapy plan for the day that you think you're going to execute, and they might come in and they don't feel well. The medication that they took didn't sit well. Maybe they didn't eat breakfast. Maybe they've got to go to the bathroom. Maybe they didn't sleep well. There's all these little seemingly small factors, but they really add up to the bigger picture of it's impactful for their day, and it's impactful for the way that they can interact and participate in therapy because they're distracted, right?
Yeah, and I think that's such a huge part of therapy that we as therapists forget because we're worried about our, our SMART goals and our this and that, that when somebody sits down, like what makes a difference in your life? Like you as a couple, what's the thing that you guys are fighting over the most? What is it? And it might be she can't cook anymore. That the husbands love to bring in their wives and say she can't cook anymore, fix her. Or it's the repeated question, it's whatever it is. Oh, okay, well, that's our goal for today. Like, how are we going to fix this one thing and make tomorrow just a little bit better on that? And
Hmm.
yes, we'll use our goals along the way, but we're fixing your life, not making my paperwork look good.
Yeah, no, and I had a patient with Alzheimer's who his wife's beef was he used to go upstairs and get dressed. He was known for his, very well put together outfits, and it was hard for him to do that. But then when I did some probing and some digging, I found out that other family members were coming in and setting up his outfit for him. And so I said, "Well, give him ownership. Pick two outfits and or have him pick because he was like one of those people that matches the colors of everything down to the shoes, right? And so give him the color choice. What color do you want to wear today? And then give him a couple of options and let him pick because he can still have that autonomy and that independence, but maybe he doesn't have the initiation to go upstairs and go pick those things out. And if they're not grouped together, then he's going to abandon the task because now he's already lost if he's able to initiate. So there's a lot of, again, those these multi-layered pieces that people who aren't in the field and who haven't spent time treating these cognitive disorders, we just assume that they know, but they don't know. The community education is still bad for these disorders, and people, just the general population doesn't know, and they certainly don't know what to do with it. And then, like you said, they play the blame game. Oh, the other one we always hear is, well, she can't hear me or he can't hear me. We see that a lot with our patients with dementia, right? And sometimes it's
Yeah,
not that they're not hearing them, because we know that a lot of those patients have hearing loss, but a lot of it is that they can't attend. So now
yeah.
the spouse is mad because they weren't listening. But they were, they
And
just
that
didn't attend to it.
and that's like probably my favorite. I sound like such a jerk. My favorite thing to do with people, but is I'll read a long paragraph and afterwards tell me back what you got out of that.
Mhm.
There were twins and there was something about a mirror. And I'll look at this. You guys know the test, you know the test, right? And I'll look at the spouse and I'll be like, okay, so you come home and you say blah 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 blah, and Mary said, and then this happened and this happened, and by the way, can you get the hamburger out of the fridge? And then blah 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 blah. And they come back with nothing. Like that's the equivalent of what we just did there, and that's real life. Like there were twins, something about a mirror. So it's just having the family there and being able to do that kind of education all the time is, I think, pretty meaningful.
Yeah, those concrete real life things that happen. We had someone else who said, I hate to bring up insurance. This
Uh,
is funny because we were talking about this earlier. I work in home care, and insurance and companies do not put much merit in cognitive therapy, and I feel like we aren't given the off to even try. Yeah, this is a big bone to pick for me, because I said this earlier about how we'll get a TBI patient who's 30, 40 years old, and they get 4 visits, maybe 5 if you're lucky, and then you have to go fight for more. And well, they really need more physical therapy. They can think fine.
Uh,
But they can't find the forest for the trees, and they certainly couldn't go make themselves a bowl of cereal if they had to. So that part is really frustrating.
and
And I
I
think
don't know if I have.
no, I was gonna say, I think there's a big push for a lot of us who are being loud about it, but it's not necessarily changing things as quickly as we would like.
And I do a lot of standardized testing and try to look at higher level tests, the favors, the you know test of everyday attention, ABCD, just try to find higher level so I can find those standardized scores, because if you test enough areas, you find the deficits. And so I'm having okay luck with the insurance companies. Sometimes it's me and them on a phone call justifying my case. I mean, I'll be real honest. Sometimes it's great. I have occupational therapy and you get to see occupational therapy instead of me. And I get very frustrated by that. And, you know, that's one of my workarounds is OT tends to get covered better. And it's something I hope that we get to continue to work at because it's not the best solution. They're amazing at their job, but we do different things.
Mhm. Yeah, no, for real. And then someone else just said, "I recently listened to a speech by a patient with CTE named Stephen Barbieri, and it was pretty mind-blowing hearing about the improvements he's seen from speech therapy." Well, and you gotta remember with CTE too that that might be a preliminary diagnosis, but you can't actually have that full on confirmed diagnosis unless it's postmortem. So, they might be able to have some clinical basis for calling it that, but yeah, no, CTE that's something that I actually spoke about. That's actually how I met Tiffany was at ASHA last year. I did a talk on post-concussion syndrome and CTE, and it's that's another area where it's kind of becoming this niche area for a lot of SLPs who are working with athletes to try to promote brain health for prevention, but also getting in that door so that they can get those referrals because again, we're working with physicians who may not realize that this is an area that we are those of us who are working in that realm are versed in and can provide services and provide help to these patients and their caregivers.
Yeah. And it's really tragic to see especially the high school students with the post concussive syndrome, that it isn't understood. And all of a sudden they've got the sunglasses, the tight hat, they
Mhm.
quit their sports, they're depressed. And the answer is, here's an antidepressant.
Yeah.
And I'm like, no, that is not the answer. Like, here again, have mom and dad watch this person try scanning and just crossing out the letter E's, in a couple sentences, and they miss three of them. Like, this is the visual of what's going on in this kid's brain, and we need to help them. And it's not necessarily throw drugs at this brain. It's how do we rehab this? So yeah,
Mhm.
just getting ahead of that's a big deal.
Yeah. And we had another question. Can you tell us more about the standardized tests you give that insurance will be more apt to pay for? I'm not sure that insurance is necessarily paying for the standardized test versus the evaluation process to begin with. Does that make sense?
Yeah, so it's not like I'm saying, boy, this is the test that insurance is going to pay me for. It's how am I going to prove that you do have deficits in attention? Or how
Mhm.
is it that this is that we're going to prove that you have problem solving or memory or attention or whatever the thing is. So it's not necessarily like insurance is going to pay for me giving the scat B.
Mhm. Yeah, it's the overall evaluation and collecting data to ensure that, like it's basically like trying to prove a case. Like if we were an attorney and we're trying to prove something, that's kind of how it feels sometimes. Is that like you said, you're shooting different tests out there so you can get that specific subtest that gives you that data. Let's see. Is there any benefit for people with dementia or Alzheimer's doing activities like word search, crossword? I've heard the answer to this is no, and it does kind of seem like busy work when I've done these with family members, but at the same time, it seems better than them just staring blankly at the TV, for example.
I had a running joke when I worked at the nursing home. If I walked in and a lady was, or man, was doing a Sudoku puzzle, I could just turn around and walk out. but crossword puzzles are reliant on long-term knowledge. So you can have a concussion, a stroke, and you can still do your crossword puzzle because that's reliant on, long-term memory. But a word search, there again, if you take the word search, fold it over so they can't see the words and they have to remember the word they're looking for and they only look for the one word, that's an awesome attention exercise. So
Mm-hmm.
it's not just busy work, but it is you explaining this is why we're doing this.
Mm-hmm.
If you give somebody a word search in therapy and walk out, they're going to walk out and say, I did word searches today. If you give somebody a word search in therapy and say, you are doing this because I bet you can't hold on to that word long enough to find it and you're going to get distracted by another word, that's a problem. Like, this is
Mm-hmm.
why we're doing it. All of a sudden, they're like, oh, I worked on attention in therapy.
Mm-hmm.
So,
Yeah, no, I think that's a great explanation. And just as we're wrapping up, I want to mention, like you have said this kind of already, but you're in rural South Dakota. What does it mean to bring brain health services to small towns? And what do you think other SLPs can do to kind of follow the lead? Because again, my version of a small town is very different than, I worked in a rural hospital in a bigger city, but we are the largest landmass city in our Commonwealth. But the hospital itself is located in the farmland section, but then you drive 10 miles away and you're in the city. So I think it's the rural part for you is a lot different than it is for where I was working.
yeah, it is absolutely vital. I grew up Bristol, South Dakota, even smaller than Aberdeen. So, I graduated with 8 kids. It is so important that I know 8 kids. I was in the top 10 of my class, but
It's
we all were. It was amazing. It is so important because I look at brain health and I look at these small communities and, you know, church is a dying thing.
mhm,
The senior center is a dying thing. So I look in my little small community and what used to have a really active volunteer group with the church and the senior center and all these things, there's not that anymore. And if we don't get people understanding in rural America that you've got to work at your brains and that being social matters and that stimulating your brain matters and making better food choices matters, what happens is, mom and dad move into in our area, it's Aberdeen. They move into the bigger city. Well, that's two more people not bringing their family to the restaurant in that town. It's two more people not supporting the gas station. And it's rural South Dakota dying if we don't keep working at this. So it's really important to me. And I speak all over the state on brain health for that reason, because it's everything to me, like the little farm town and my parents' farm. Like, it's important that they stay active.
yeah, no, I think that's a great example because you're so right. And we're seeing even where I live, people will come in who aren't, because again, it's a highly military community. They'll come in and they move sometimes to a smaller, more rural spot than where they're stationed. But then what happens is they stay for 3 or 4 years and then they get stationed somewhere else and they leave. And it's the same kind of thing. Now they're leaving a house where a lot of apartments have gone up and now these apartments are here and there's no one living there or there's limited people and the rent is at like astronomical. People are paying $2,000-3,000 a month for a 1 to 2 bedroom apartment for rent and it's just kind of crazy. So if we don't foster the community and we're not providing education in our communities, we're not going to be expecting for our age group or younger to have a better community education on these preventable diseases and certainly on things like when I say preventable I mean things like diabetes, hypertension, heart disease, but we know that they coincide with things like dementia. They coincide with some of the other progressive neurological diseases. It doesn't mean you'll get it, but it means that you might be at a higher risk. So we have one more comment, and then after this, we'll kind of wrap up. My mother lives on her own. She's 75, demonstrating signs of dementia, but has not been diagnosed. She refuses to allow me to attend her annual visits with the primary to discuss with her doctor our concerns and recommending a neurologist that specializes in dementia. Unfortunately, she argues with us to the point it becomes unhealthy for all of us, so we avoid the topic. My grandmother had dementia. What do you recommend? That's so tough.
It is so tough. And my thing I would ask is talk to the general physician and find out in your community, is it a speech pathologist who knows, who specializes in this area? Like, who is the expert, so to speak? Is it speech in that case, or is it OT in that place? But ask that doctor for a referral to one of them first before the neurology appointment, and just say, Mom, there's a lot of studies that if you get ahead of this, and we can work to improve your brain. Like, you do physical therapy for your legs, you're going to do this kind of therapy for your brain, because we want you to stay really, really strong. So can you seek that out? Because we want to do everything that we can to keep you staying at home. I think people think they go to the neurologist for the diagnosis of dementia and then they better be packing up their stuff and headed to the nursing home. And
Mm-hmm.
so then that therapist can say, hey, let's get to a neurologist. Let's find out what the root is this of this, and work that way around it. That might be a little bit more helpful than starting out the other way.
Yeah, I agree. Well, Tiffany, thank you so much. This is so great. And, it's always lovely to talk to you. And I just really appreciate your willingness to come on and share such a wide variety of topics because I think we covered a lot.
We did. And Renee, I have to say, when I went to ASHA and afterwards, I'm just like, ooh, I'm just gonna get a selfie with Renee Garrett. This is pretty cool.
Stop.
So now I
Stop.
get to be on your podcast and like, wow, like
So funny. Oh
this
my
is
gosh.
this is
Like hot blushing, but that's so sweet. But yeah, I think this was a really great episode. So I really appreciate you taking the time to come on and, you know, think about what you wanted to talk about. And so, of course, you're welcome back and come visit anytime. Tiffany, thanks again. Good to see you.
yeah, you too.